Kia ora, my name's Gilly Davy and I am a senior neurological physio and the founder of MS Get a Head Start. I'm based in Auckland here in New Zealand, and I'd like to take this opportunity to give you some of the feedback I have from when I attended the ECTRIMS and ACTRIMS MS conference in Milan last year. So first of all, I'd like to have a huge thank you to New Zealand's Multiple Sclerosis Research Trust, because they very kindly funded for me to be able to attend. And as you can read in the picture there, it was the world's largest meeting in MS. So an amazing opportunity to be able to go from New Zealand and represent what we are doing in the little part of the world that we are based, and actually see what is happening in the rest of the world. So fantastic opportunity, an amazing place to network. I'm sure you might have heard from some of the other feedback from the other attendees. It was huge, 9,000 people. So it was a busy place to be. There was a lot of talks going on. There was definitely a lot of time spent, looking at the brochure and working out what would be obviously the best things to attend. And for me, it was mostly trying to really navigate myself around finding anything to do about exercise and that kind of MS well-being and holistic approach, but also what were some of the latest movements in the medical world as well, to try and stay up to date. So here is just a few of the kind of real take-home things that I took away from the conference. One of the first ones was Daphne did a really interesting talk about fatigue. And as we know, 80% of people living with MS struggle with fatigue, and it's something that is still quite poorly understood. And her presentation, as you'll see here, was about really trying to get a better understanding of the difference between motor, psychological and cognitive fatigue, because we know that they can present all very differently, and really highlighted that in the current health service, and especially this is worldwide, but specifically, it does happen in New Zealand, that no one's really testing fatigue. And, from a point of view of trying to break it out with, is it motor, is it psychological, and is it cognitive? And then on top of that, how is cognitive function being tested? So one of her recommendations was the use of the modified fatigue impact scale, which I have gone and changed my practice to do that, and we've changed that on the MS Get a Head Start site as well, so helping lots of other health professionals around the world to move towards using this study. Instead of previously, I was using the fatigue severity scale because it was quite a quick and easy scale to administer in a therapy setting. However, the modified fatigue impact scale is not that many more questions, so still can easily be delivered in a therapy setting, but it does actually break the fatigue down into motor, psychological and cognitive. And we found that these results that we're getting is really valuable to help a lot of individuals with MS understand that a lot of their fatigue is psychological and cognitive based, and often, the motor fatigue they feel is because they're fatigued in their brain, their cognition, and actually by going and exercising, their cognitive fatigue improves. So that's been a great clinical change that I've made since attending the conference. And also this, I suppose, movement forwards in the use of TDCS, so that is transcranial direct current stimulation. So it's where they've got a magnetic coil that they put, it's outside the brain, so you're just sitting there, normally, comfortably, and they've got this magnetic coil outside that they situate just above your brain over a particular point in the brain, and it's obviously connected to a box that produces this direct stimulation current. It's been used in the research world for quite some time now, and it's just starting to be used to in the clinical setting for priming the brain, but also for things like testing, like things like improving cognitive fatigue. And I thought this is interesting because it is, though it's not available here in New Zealand at the moment, it is a piece of equipment that is not ridiculously expensive. So it could be started to be used in, Te Whatu Ora settings or potentially some private practice settings. And it's starting to prove some good results. And it's obviously not invasive. So from a medical point of view, its risk factors are super low and it's not invasive. So it will be really easy to see where the further research goes in transcranial direct current stimulation. And then also how viable that is to potentially roll out here in somewhere like New Zealand. The next study was a great, the next kind of real key bit was great. This was by Brian Sandroff, and this was a bit of a special one for me because it's always really reassuring when you tootle along to a conference to get updated on the latest research, and you've actually read lots of those latest research papers. So it was an amazing opportunity to actually listen to Brian Sandroff talk about this paper that he published called Primers, which stands for Processing Information of Multisensory Exercise-Related Stimuli Conceptual Framework. And what essentially he's done is that we know there is a huge amount of published evidence about the benefits of exercise for MS. However, we're not able to really quantify the effects that exercise is having on a molecular cellular kind of brain structure function. We know that exercise has the potential to have a neuroplastic input and does have the potential to essentially slow down progression. However, this is really hard to prove in the research. And the reason is because the research isn't actually studying neuroplastic-based exercise. So the way I can describe this, that in the stroke population and now in the Parkinson's population, we know that to be getting neuroplastic change, we need to have people puffing and panting out of breath, working really intensively hard to get that heart rate up, as well as really high dose therapy. So we're looking at intensive input, kind of 3 hours a day in the stroke world for, 4 to 6 weeks solid. In the Parkinson's world, we're looking at an hour every day for a month solid or more. So they're intensive, they're high repetition, they're hard work, this multisensory exercise-related stimuli in the sense that it's novel, it's engaging, it is challenging. So there's principles around neuroplasticity which we're taught as therapists. But unfortunately, lots of the exercise that's being researched in MS is people going for a walk 3 times a week, or someone attending Pilates class twice a week, or someone doing a strength and conditioning session once a week for 12 weeks. So they're all lovely and showing some nice functional changes, but none of these published studies are showing any brain changes. And what Brian Sandroff was saying, well, that's not surprising because the research isn't actually delivering evidence-based neuroplastic principles. And this is something that I'm really passionate about because we're in our clinic, we're trying to deliver real neuroactive exercises, and really treat people intensively, but the research world hasn't really caught up with that. So this was a really great talk to be involved with and to have. I had a discussion with Brian afterwards, and he really does hope that there is a bit of change with what people are now trying to get funded from an exercise research perspective, that it is actually a more neuroactive, where people are being treated more intensively and with more challenge and more kind of neuroactive exercise. So I think this is an exciting space to watch what happens after this. Another real highlight was the opportunity to meet Robert Bottle in the exercise, physical activity physio world. And Robert is probably one of the most published researchers around exercise and MS. He co-authors a huge amount of publications every year in the world of exercise and MS. So it was a real honor to have the opportunity to meet him and have a little bit of a chat. I did kindly try and invite him to come and spend some time in New Zealand because it would be amazing to have him here. And he did say that New Zealand was somewhere he'd like to visit. And he gave a really nice talk about one of the papers he's recently been involved with about looking at walking dysfunction in MS. And I think what was really profound about this is we know, well, I know, I've been working in this world for a while, that we know that if we can treat people newly diagnosed with MS, we're going to have better long-term outcomes. And this is a great study to support this approach for that newly diagnosed, because even at diagnosis, you can see here that on average, that someone who is newly diagnosed is already walking 40% less steps than a health match control. And it is that very simple equation of if you don't use it, you lose it. So if at diagnosis, we've got individuals who are 40% less active, so 40% less step count, they're already going to be getting weaker and, losing fitness and losing that function. So this was a great kind of talk and paper about really trying to promote neurologists, MS nurses, that we need GPs, we need this referral at diagnosis for individuals referred directly to physio, so we can actually get this daily step count up to what healthy controls should be, because when they're newly diagnosed, they should be relatively minimally impaired from a motor point of view. So we've got that opportunity to really enhance that. So it's great to have that research, really supporting what we're trying to deliver, but also to really up that newly diagnosis referral. And another great opportunity was to meet Ulrich Theoglas, who again is a very big name in MS exercise and research. And he did a really great talk just about MS and physical inactivity. And I just really liked this slide that he highlighted, that we know that there's an element of a disease process. It's unfortunate that MS, the demyelination on the central nervous system, there's not a cure yet at the moment, and that we can't stop the progress. There's lots of disease modifying drugs that are definitely having an impact and slowing that process down, but we know there's an element of progression that's there. So we know that that can cause a worsening of symptoms. However, what we also know is that there is a huge amount of deconditioning and physical inactivity due to a number of reasons. And what he really highlighted was that with this inactivity, it's actually modifiable. And that was great to see, like just something really simple, that nice big green circle there, that you can't change the diagnosis of having MS. And unfortunately, you can't necessarily change some of the worsening of the symptoms if they're directly related to the disease progression. But you can change deconditioning and inactivity levels, which we know has a potential positive effect on slowing disease progression down and a potential positive effect on reducing symptom severity. So again, really great talk to, promote this benefit of being physically active. And then last little bit of some tidbits that I kind of came away with is that vigorous physical activity lowers the risk of an MS diagnosis. So, I obviously work in the field of MS, that a lot of people are concerned about, their family members, their children, grandchildren, what are their risks of potentially getting MS if they've already got the diagnosis themselves. Well, the best piece of advice was vigorous activity. So that's getting puffing and panting out of breath about 3 to 4 times a week. So if you've got a family member, or you're worried about, or maybe am I at more risk of getting MS because I've got, people I know that have it, well, really focus on getting super fit and strong, and maintaining that vigorous activity will reduce your potential MS diagnosis. Brain atrophy is less for those who started early on first-line disease-modifying therapies. So again, just a great piece of advice that, starting on regular medication is pretty daunting for a lot of people, but to actually just see that the hard evidence is there, that your brain atrophy, so the amount of brain mass volume you have, is going to be significantly better the sooner you start on proactive disease-modifying therapies. So, you know, gone is this view of, oh, we'll just wait to see what happens over years to come. It's like, get on the medication as soon as you can, because the outcomes will be better. And I briefly mentioned this in one of the earlier slides, is that we do need to be more formal in measuring cognition. Otherwise, it's too subjective, and it's hard about who this falls with. Is this with neurologists, GPs, MS nurses? And I feel like we need to have a good discussion, you know, in the healthcare world of, you know, what is a good measurable cognitive test that can be delivered in a clinical setting, that isn't going to be costly, time-wise, or financial for health professionals to actually be really measuring cognition better. So yeah, so it's been a great opportunity to go to ECTRIMS, and I really hope I get the opportunity to go and even present some of my own research, which I've started doing at the moment over the next couple of years. So it was fantastic and learned a lot, and hopefully that's given you guys some little bits of information to take away as well.